Thank you for joining the American Lung Association's Community Connection series presented by Wellstar Health System. Please welcome our moderator for today's Community Connection, the Executive Director of the American Lung Association of Georgia, Michelle Howell.
Hi, thank you, Rebecca. So thank you for everyone for attending today, and welcome to today's Community Connection on lung cancer. We are so glad to have you all tuned in today to hear more about this important topic. We are excited to partner with Wellstar Health System for this 4-part educational series. The next Community Connection will be in January for part 2 to continue this conversation about lung cancer with Dr. Price. So make sure to stay tuned for more information on that. But to start us off, I am honored to introduce our keynote speaker, Dr. Mayfield, thoracic surgeon with Wellstar Health System, medical director of lung cancer screening program, incidental pulmonary nodule program, and multidisciplinary oncology clinics. Thank you so much, Dr. Mayfield, and welcome.
Oh, thank you. It's my pleasure.
So we have a question and answer style set up for today. And with this, we've had some questions come in from attendees and so we will go ahead and kick it off if you're good to just start with questions for you so everybody can learn more about this important topic. So the first question being, what is the current burden of lung cancer and how does it compare to other cancers?
Thank you. That's a very good question. And I think most people are going to be very surprised by the answer. Lung cancer is the #1 cause of death of cancers worldwide. It kills more men in the United States than colon cancer and prostate cancer and pancreatic cancer combined. And actually in women, it kills more women than breast cancer and cervical cancer combined every year. Now, what is that number? It's about 155,000 people per year of lung cancer, but that's a very abstract number when we just talk about population. So I look at it in a slightly different way. An airliner that crashes somewhere in the world kills about 422 people, and it becomes an international incident. It's at the top of every newspaper. It's on the newsreels and the headlines. The NTSB gets involved, governments get involved. There's this huge alarm about that. Well, it turns out that 422 people die in the United States every day of lung cancer. It is an airline crash every day, but you don't have that same sense of urgency and that same alarm and the same wanting to address the problem.
Thank you. So the second question we have for you is, what are the chief risk factors of lung cancer?
Another great question. So it goes without saying that smoking tobacco is the #1 risk factor for lung cancer. And stopping smoking has reduced the incidence of lung cancer, particularly in the state of Georgia. About 40% to 45% fewer men smoke now than smoked 20 years ago. And as the smoking rate has decreased, there's also been a linear decrease in the incidence of lung cancer and lung cancer death in men in Georgia. Unfortunately, women have been slower to stop smoking, and their rate of decline in lung cancer has been slower in the state of Georgia. That having been said about smoking, about 20% of patients who get lung cancer never smoked. And there are a number of risk factors for that, which include radon exposure, which is now decreasing with our better home building techniques now, and then exposure to heavy metals. Having been in the military and particularly exposed to the burn pits doubles the risk of lung cancer. So there is some occupational exposure, and there may be a family history, but we've not clearly delineated genetic predisposition for lung cancer like we have in breast cancer.
That's great information. I'm sure our attendees on here are very appreciative for that. So we have another question for you. It would be, how can we decrease the incidence of lung cancer?
Well, because 80% of lung cancers are associated with tobacco abuse, then the primary means by which to reduce lung cancer incidence is to eliminate the use of tobacco products. I'm not sure that doing vaping rather than smoking is any better solution, because there are thousands of chemicals in these vaping devices that we have no idea yet what they do long term. They just don't have the long term history. So the chief means by which to decrease the incidence of lung cancer is smoking cessation.
Perfect. Thank you. Next question that came in was, why does lung cancer seem so deadly?
Excellent question. So I'm sure all of you have heard of an aunt or an uncle or a grandmother or grandfather who went to the doctor and got a chest x-ray, and they were coughing, maybe coughing up a little blood, and then they died of lung cancer 3 months later. Or the first thing that we saw as a manifestation of their lung cancer was seizures from a brain metastasis or a broken bone from bone metastasis. So it turns out that in the early stages of its existence, lung cancer start very, very small, as small as a BB, and then they grow to a size of a pea. Then they grow to a size of an acorn, and then a walnut. And all that is completely silent. You don't feel it, you don't know it, but that lung cancer is growing in there. It's not until it manifests symptoms outside the lung, the brain, the bone, the adrenal glands, or one starts coughing up blood, that we know that there's a lung cancer there. So the reason it seems so deadly is that 80% of the time, we don't detect the lung cancer until it has already spread outside the lungs, and when it is very hard to heal, very hard to cure.
Perfect. Great. Thank you for the information. Next question that came in was, how can we detect lung cancer early enough to cure it?
See, so 80% of the cases that currently present into a doctor's office are in what we call stage 3 and 4. They're advanced. They've either spread to the lymph nodes in the chest or they spread somewhere outside the body. 80% because it grows silently. So how do we turn the tables on that? And that's through screening. We've had screening with mammography for many years. We've had colonoscopy for colon cancer screening for many years. But in 2012, we got lung cancer screening approved. And lung cancer screening is a process. It's not just a simple one-time test, but it's a low-dose CT scan performed on what we call high-risk patients annually, every year. And it's not a single picture, it's a series of pictures creating a movie so that we can look for changes of little nodules in the lung. So the short answer is we can detect lung cancer early enough to cure it by using low-dose CT scanning, primarily in patients who are 50 to 80 years of age, have had a 20-pack year history of smoking. That means they smoked a pack a day for 20 years. And they have not quit within the last 15 years. So you're going to have smoked within the last 15 years. That group, the United States Preventive Services Task Force has said that's the group that needs to be screened. When we've done that at Wellstar, we've been screening patients for lung cancer for 15 years. 71% of the patients that we do lung cancer screening in, we discover their lung cancers in stage 1 and 2. Curable. Just take it out or take it out in a little chemo and it's cured. So instead of 80% coming in at an advanced stage now, in our program, that if you have a screening cancer, only 29% are in stage 3 and 4. So we're shifting the stage with lung cancer screening.
Thank you. And I know we have more questions. This was sent in from an attendee that So COPD patients have an elevated risk for lung cancer. What type of screening and how often should patients undergo evaluation?
So the United States Preventive Services Task Force, called the USPSTF, has looked at the statistical criteria for who benefits most from lung cancer screening. The NCCN, National Cancer Care Network, also developed a separate set of guidelines. So COPD is considered what's called a secondary indication for lung cancer screening. That would be in addition to a history of smoking at least 20 pack years. So in the original NCCN guidelines, we could do lung cancer screening on patients that smoked for 20 years and had one other risk factor, which included COPD. So specifically, if you do not have a 20 pack year history of smoking, but you have COPD, then you wouldn't qualify under Medicare guidelines, USPSTF guidelines, or the insurance guidelines for screening. However, in a conversation with your individual physician, if because of family history, tobacco exposure as a child, the development of emphysema, you and your physician feel strongly that you are at an elevated risk for lung cancer, that physician can write an order for low-dose CT scanning and refer you to a screening center. And we have a number of those.
Perfect.
Oh, it says how often should patients undergo evaluation? So lung cancer screening is an annual low-dose CT scan. So it's done once a year, unless we start seeing a little change in what we call a nodule or a little change in a spot in the lung, then we might order something at an elevated frequency.
Thank you. So we have time for a few more questions. So if you don't mind answering, we'll just keep going. So what is the effect of time on the progression of lung cancer?
You know, most people don't even think about the time once they get a diagnosis. So Cleveland Clinic published a paper in 2019 that was extremely informative. And it discovered that once you have a diagnosis of lung cancer, every 2 weeks, delay in therapy resulted in a reduction in 2% of your 5-year survival, of your ability to be cured. And in many cities across the country, it takes 6 weeks, 3 months even, to go from an abnormal CT scan to your first treatment. Well, by that time, we've reduced your potential long-term survival by 30%. So time, once a diagnosis is made, is critical in going from that diagnosis to your first treatment. And at least at Wellstar, through our multidisciplinary oncology clinics, our care model for lung cancer in the STAC clinics is a 2-week period from presentation. So if you present with an abnormal CT scan, we'll have diagnosis and staging in the first 7 days. You come back, and then we'll start treatment in the next 7 days. Now, there's our model. Not every single patient can make that model, but that versus 90 days dramatically improves 5-year survival. So time is your enemy once you have a diagnosis of lung cancer.
Great information. Thank you. Next question. What are some recent breakthroughs that improve lung cancer survival?
So this is where the opportunity comes. This is where hope comes from. In the last 10 years, we've had the development of what we call monoclonal antibodies. And that is, you'll also hear it called targeted therapies. So many of these cancers display genetic aberrations in them, and we can detect those genetic aberrations and then actually apply monoclonal antibodies to those cancers. So if you have an EGFR mutation or KRAS or ALK mutation, then there are specific monoclonal antibodies that can be applied against that. Monoclonal antibodies are slowly starting to replace chemotherapy as the primary therapy for at least secondary, and now moving into primary therapy for later stage lung cancers. So the big breakthrough has been the monoclonal antibodies. And then the second is immune therapy, being able to identify cancers that express what we call PD-L1. And if you have this PD-L1 expression in the tumor, then we can give you medicine which helps your immune system to attack and get rid of the cancer. These are huge breakthroughs that are improving survival and decreasing the side effects of getting chemotherapy.
Great information. Thank you. Next question that came in is, should lifestyle changes be made after lung cancer diagnosis, such as diet, exercise, etc.?
Wow, the dietitians are going to kill me on this one. I'm not specifically aware of any dietary changes that should be made. There may be some vitamins that are helpful, but I'm definitely not an expert on that. Smoking cessation is imperative. We know that if a person continues to smoke after treatment and cure of one lung cancer, they're at much higher risk for a second lung cancer. So you got to stop smoking. Furthermore, stopping smoking decreases your risk of stroke, decreases your risk of heart attack, decreases your risk of ischemia of your legs and that kind of stuff. We've also seen in our cardiac rehab population that regular exercise, say after a heart attack, dramatically improves your long-term survival. So not an expert on diet, but you got to stop smoking and absolutely promote exercise after a diagnosis and treatment for lung cancer.
Great, thank you. Next question, do people who previously smoked but have quit over 5 years ago still need to be screened for lung cancer?
Yes, in fact, it's even written into the guidelines that we would still screen you out to 15 years from after the date that you stop smoking. There's actually what's called a PLCO model that would say that if you're a 50-year-old female that quit smoking at 50 and wanted to start getting lung screening at 65, you really wouldn't qualify for lung cancer screening on your 66th birthday. But the PLCO model would say that you're actually at increasing risk of lung cancer after that 15 years of cessation over time. So the short answer is yes, even if you quit smoking 5 years, you still should get screened. And in fact, you would qualify for screening until you had smoking cessation for 15 years.
Perfect, thank you. And then next question being, is lung cancer more or less genetically linked than other cancers?
I can only give you an anecdotal answer. That is, there is not good published research that I'm aware of that shows specific genetic predispositions to lung cancers like there are in breast cancer. That having been said, we see BRCA1 genes in many adenocarcinomas of the lung, adenocarcinoma being one of the cell types of lung cancer. And we know from what we call anecdotal experience, or having done this for 30 years, that patients that have a first-degree sibling, or especially two first degrees, like a mother or father and a sibling that had lung cancer, they're at higher risk for lung cancer. I'm going to screen those patients off a protocol.
Great. And we had a question come in. It says, is there an ethnic population more susceptible to lung cancer who would benefit from frequent screening?
So that's a really hot topic right now. And it's believed that African-American men actually are more susceptible to tobacco than Caucasian men. And unfortunately, African-American men are less likely to seek healthcare, even if they are symptomatic with something that might be a lung cancer. So a lot of what the National Lung Cancer Roundtable is doing at a national level is addressing disparities in access to lung cancer screening. And there will be a very broad education program and movement to address those populations who have not had good access to lung cancer screening.
Great, thank you.
We had another question come in the chat, and it says, can you share any words of wisdom in starting an incidental lung nodule program? Do you use particular software for this? Thanks.
Yes, so there are two types of incidental lung nodule programs in the country today. One, which is used by a very large health system in the Midwest, they just highlight the incidental finding with a different color in the radiology report. They send a copy to the patient, they send a copy to the doctor. That really doesn't change the system of care around that, and there's no way to close the loop that anyone ever saw the report and that anything was ever done about it. But that is one way to do it. The other means by which to do an incidental nodule program is to use software, a natural language processing engine that goes out every night and looks for radiology reports that report an incidental finding in the lung. Our program brings those into a work queue, and we have staff who go through those reports and then use a very strict protocol on either unreferring those patients because it was not a significant finding, or referring them into the program for further evaluation. That particular software is it's a lung cancer orchestrator. It's also been called Lung GPS, but I think that's being discontinued now, Lung Cancer Orchestrator. That includes this natural language processing engine, and then the patient management software after that. One thing that's possible to do in either a screening program or an incidental nodule program is to lose a patient because they didn't show up for another study and not have some sort of software to trigger and let you know that that patient didn't show up or didn't get something done. So these software packages are meant to leave no patient behind, and keep looking out there for that patient and make sure that they're followed up. I hope I answered your question adequately.
No, that was great.
So I think we have one more question if we have time for it.
Yeah.
This question says, is there a connection between COVID and lung cancer that has been found?
Not that I'm aware of.
And then maybe one more question. I know we've talked about this a little bit, but what is the official criteria for being eligible for lung cancer screening?
Okay, USPSTF guidelines and Medicare guidelines are 50 to 80 years of age, a 20-pack year history of smoking, and not have quit you must have smoked within the last 15 years. That is, if you quit more than 15 years ago, they won't screen you. So those three criteria. And you have to be referred by a physician with a physician order.
And we also have the American Lung Association has Saved by the Scan program, and you can go to savedbythescan.org and fill out a quiz in order to see if you would be eligible for that lung cancer screening. Then we had one more question come in, and that'll be our last one.
Okay.
And it says, is there any connection between asthma and lung cancer?
So according to the NCCN guidelines that were published about 10 years ago, if you had a 20-pack year history of smoking and in addition had asthma, COPD, or some other underlying lung disease, then it puts you at elevated risk, and you would qualify for lung cancer screening. In the absence of tobacco abuse, asthma alone is not a risk factor for lung cancer.
Great, thank you. And I think that will wrap us up on time. So just a huge thank you to you, Dr. Mayfield, for all the great information that you shared. Thank you so much for everybody that attended today. We have recorded it, so we'll be putting this out. We can email it out, and we'll also have it on social media. But again, this is just the first part of a 4-part series that Wellstar is sponsoring. So in January, we'll have a second continuation of our talk about lung cancer with Dr. Price. So stay tuned for more information on that, and just thank everybody for coming out. And again, thank you, Dr. Mayfield, for all your great information.
It was a pleasure, Ms. Howell. Thank you.
Have a good day, everyone.
You too.